Thank you so much. This is my first time here at DTRF. It's been really great so far and really, really happy to be here. So I'm a colorectal surgeon. I'm not a sarcoma specialist, but I direct our colorectal cancer hereditary center, and we have the privilege of probably taking care of the largest registry of FAP patients here in the United States. So we do see a lot of patients with desmoid disease. So no disclosures, but I do have a lot of surgical pictures. So I know we just had lunch. So whoever doesn't have the stomach for it, please don't look at the slides. So getting right into it. So desmoid disease in FAP, it's a leading cause of morbidity and mortality in FAP. We know that desmoids don't metastasize, but as everyone here knows, the local destructive nature of these tumors leads to significant morbidity related to bowel obstructions, fistulas, ureteral obstruction, and bleeding. This will be presented at the CGA meeting in November in Philadelphia. So we recently looked at our registry, which was started in 1979, and we looked at causes of death in FAP patients. And since the inception of our registry, we have 255 patients that have died, and we looked at causes of death. And we were happy to see that colorectal cancer, which is still the #1 cause of cancer-related deaths in patients with FAP. It went down as a cause of death. It started at 45% and we're down to 22%. And that is clearly due to improvements in prevention of colorectal cancer, but also in treatment of colorectal cancer. When you look at desmoid, which is that light blue curve there, it's really a flat curve. It was 15% back in 1995, and it's now 16%. And so really there has been no improvement in desmoid-related mortality, and that really is the reason why we're all here today and what we're trying to change. We need to figure out ways of how to treat desmoids better because we really haven't had any significant shift now in 30, 40 years maybe. So until that treatment is here, though, really what we want to focus on is prevention. You can see this is a disastrous desmoid, a mesenteric desmoid, where surgical treatment is not ideal. Medical treatment often does not do much. So really, what can we do to prevent this from happening to begin with? So we know that besides some of the known risk factors for desmoids and FAP, surgery is really one of the big inciting factors. We know that for many desmoids, surgery can incite desmoids. Now, the hard part in FAP is that without surgery, almost 100% of patients will develop colorectal cancer. So surgery is necessary in patients with FAP. There are, however, two most common types of surgeries that we do in FAP. One is a total abdominal colectomy, where we remove the entire colon and then attach the small intestine to the rectum, otherwise known as an ileorectal anastomosis. The other common surgery, which is probably more commonly done, especially here in the United States, is a total proctocolectomy, where the colon and the rectum are removed, and we create an ileal pouch out of small intestine and attach that to the anus, known as an ileal pouch anal anastomosis. Now, when we as surgeons do surgery on patients with FAP, we always think about desmoids. And the question we ask ourselves is, does my choice of the operation, being it a total colectomy with an ileorectal anastomosis or a total proctocolectomy with a J pouch, does that affect the desmoid risk? The other question is, does how we do the surgery, if we do it open, the old-fashioned way, or if we do it minimally invasively, does that affect desmoid risk? So that is a question we've asked ourselves for many years. And our hypothesis was that pelvic pouch surgery, where we take the small intestine and stretch it down to the anus, that would increase the risk for desmoid formation. And the hypothesis is that because we're stretching the mesentery, where a lot of these fibroblasts are, that could potentially activate scar formation and desmoid formation as well. So that was our hypothesis going into this study. And we looked at 345 patients from our registry, and about half had the ileorectal anastomosis and the other half had a J pouch. And we found 29%, so 100 patients developed symptomatic desmoid disease, which is a relatively high number and maybe higher than in some other series. We had a median follow-up of 118 months. And we then looked at some risk factors for desmoid formation, and I just want to point out some of the preoperative risk factors. And some of these are extraintestinal manifestations that we can find in FAP patients, previously known as Gardner syndrome, where they have osteoma, supernumerary teeth, epidermoid cysts. That was a risk factor, one of the preoperative risk factor. And then family history of desmoids was a significant risk factor. And then the location on the APC gene where the mutation is another risk factor that has been shown. And if the mutation is closer to the 3' end of the gene, the risk of desmoid formation is higher. And then we looked at the surgery itself, and we found that the highest percentage of desmoids were found in patients that underwent an open total proctocolectomy in J-pouch, so proving that our hypothesis was correct, that J-pouch surgery was in fact a higher risk for desmoid formation. And looking at this in the Kaplan-Meier curve here, again, that confirms that when we look at desmoid-free survival, the risk for desmoids was significantly higher in patients that underwent an ileal pouch anal anastomosis than those that had an ileorectal anastomosis. On multivariate analysis, looking at some of the other risk factors again, height, actually, we thought that BMI would be a predictive factor, but it was actually height, which again maybe goes to the whole idea of stretch on the mesentery. Height was a risk factor. Family history was a risk factor. Desmoid risk factor score, that's a score that our center had made based on some of the preoperative risk factors. And then the surgical procedure was really the strongest risk factor, with patients that undergo a J-pouch having a 6-fold higher risk of desmoid formation. Unfortunately, laparoscopic surgery, which we were hoping would end up being protective of desmoid formation, did not prove to be so. So again, the type of surgery was a significant risk factor. So just to summarize our findings in terms of desmoid prevention from a surgical standpoint, we found that total proctocolectomy with pouch is a more desmoidogenic operation than an ileorectal anastomosis, and that should be a major factor in surgical decision-making in FAP. There are other factors that go into the decision-making as well, but we think that not enough surgeons or gastroenterologists think about desmoids when they think about surgery in FAP. And we should ensure that really a proctectomy is really required before recommending that for patients with FAP. Now, in patients where we know that there are high risk for preoperatively for desmoids, we want to delay surgery as long as safely possible. We want to maximize endoscopic and chemopreventive options to treat the polyposis and thereby delay surgery and thereby also preserve desmoid-free quality of life. So that's what I want to say about prevention. Now, moving to the very other end of the spectrum here, where we have not prevented the desmoids and we're dealing with catastrophic desmoids. So surgery for symptomatic desmoid disease that encase the root of the mesentery. When you do surgery on those, you risk extensive bowel resections and the development of intestinal failure. However, total antrectomy, meaning resecting the entire small intestine with intestinal transplantation, has been described as a salvage option for select patients. However, because this is done very rarely, there's very limited data on the outcomes for this type of surgery. So we do have I'm not an intestinal transplant surgeon, but I have partners that I work with who perform intestinal transplants. And over the last couple of decades, we had 14 patients with FAP that had catastrophic desmoids, and 15 transplants were performed in those 14 patients. So some of the baseline demographics here, 9 were male. The age was 41 was the mean age. The youngest was 23 and the oldest 61. All of these patients had been on different types of medical treatments before, NSAIDs, antiestrogens, Doxil, kinase inhibitors, and others. The indication of transplant, most cases, was severe complications affecting the bowel. And importantly, these patients, all of them were on TPN, with some of them being on TPN, so that's total parenteral nutrition, where they're dependent on IV nutrition. So the average was 2 years on total parenteral nutrition. Many of them had previous abdominal surgeries and other issues. Now, looking at the type of transplants that are performed, there really are 3 main types of transplants that have been performed, and the most simple one, which is still very complicated, is an isolated small bowel transplant, where you only transplant the small intestine. And then depending on what previous surgeries the patient had, but also depending on the health of the liver, some patients need a multivisceral transplant where they also receive liver or stomach and pancreas. The surgeries are intense, 12-hour operation on average. Post-operative complications are common, and hospital length of stay, ICU length of stay, is extensive. So again, no no easy surgery for sure. In terms of post-op long-term outcomes, so mortality within 1 year, none of the patients died within 30 days of surgery, which is one of the markers we look at. Within 1 year, though, 2 of these patients died. 2 of the grafts had to be explanted. However, when you look at TPN dependence in the overall patient population, there was only 1 patient that was still requiring TPN after transplant, which is encouraging. Overall survival, again, with considering the severity of the disease that these patients start with, 1 year survival of 87% and 10-year overall survival of 79% is also encouraging, considering, again, the extent of their disease and the extent of the surgery. Now, when looking at some of the factors that predict survival, again, it's a small number, so you can't draw too many conclusions here. But one of the factors that's potentially modifiable is the length of time on TPN. So patients that were longer on TPN were at higher risk for poor outcomes after the surgery. And the reason for that, we suppose, is because those patients who are long on TPN develop liver damage, liver failure, and are then requiring multivisceral transplantations, which we see has a worse outcome, whereas those patients that were able to have just an isolated small bowel transplant, we have a 100% survival rate long term. So summarize here the conclusions for intestinal transplant. It serves as a salvage operation for FAP patients with advanced and complicated desmoid disease that leads to intestinal failure. And while transplant is associated with significant morbidity, most patients do enjoy long-term survival and nutritional autonomy. However, if we can refer patients early to centers of excellence that take care of these patients, we can potentially preempt TPN-related development of liver failure and the need for more morbid multivisceral transplantations. So thank you. Happy to take any questions.
Questions? Intestinal transplantation group, what's the post-transplant?
Sorry, the immunosuppression? Yeah, it's a good question. Most of them do not require steroids. Most of them are on tacrolimus as the main anti-suppressant. Some of them will develop failure and will get boosted with steroids and other medications. I had a slide with the exact medication. And again, I'm not the transplant surgeon, but yeah, there were two rejections that needed to be explanted. So in most of them, they can be. And the question about immunosuppression in a patient that's at risk for cancer, obviously with FAP, that's obviously something we worry about. But it's not something we have seen too much of that where we see a immunosuppression-related increase in cancer development.
Oh, great talk. It was interesting on the for your transplant slide. If I saw right, 7 patients had desmoid form. Like not that slide. I think there was a slide back. There was yeah, desmoid recurrence. I have to think a lot of that is it's hard to because you have FAP, which in itself can lead to desmoid versus the surgery itself. Like it's hard to probably tease out if the surgery led because extra abdominal. Assuming that's like extra, I don't know what sites, but obviously that shouldn't be the surgery versus, just outside the abdominal cavity.
Right. No, that's something we were very interested in. Again, we don't have that clean. It's hard to tell when you have a desmoid where exactly what tissue it arose from. We think it's not coming from the graft. So usually it'll be retroperitoneal for those that are intra-abdominal, and then abdominal wall, but also extremities. So yeah, the transplant doesn't fix the predisposition to desmoids, obviously, in these patients. However, if they don't recur in a way that they're back in the mesentery and again leading to severe intestinal complications, these patients do okay.
See that in the colorectal cancer world, are people aware that do these FAP surgeries about the difference? Just because I don't think that my surgeons are necessarily kind of privy, how much do you need to get this out?
Yeah. Yeah, so great question. And one of my pediatric gastroenterology colleagues, we recently just did a survey among surgeons that take care of FAP. Some of them, and it's a large heterogeneous group of surgeons that treat these patients. They're pediatric surgeons, colorectal surgeons, general surgeons. And we asked sort of factors that influence the decision for surgery and the type of surgery that people do. And we weren't that surprised, but we saw that most surgeons that were questioned would say that the only surgery they perform is a total proctocolectomy and pouch. And I think some of that is just because there isn't enough education out there. And I think a lot of it is also fragmentation of care where desmoids are not taken care of by the same surgeon who will do the surgery for the FAP. So it's not being considered at the time of surgery. And this data is, while our data was very convincing that pouch surgery is a lot more higher risk for desmoid formation. There have been some other studies that have not shown that. There are more studies coming out now that we recently were presented at Insight that support our findings as well. So I think even among experts, it is not that clear. But I think here in the United States, the main issue is, again, that most FAP patients are taken care of by non-FAP experts. And even, FAP people who see FAP are not that aware of the risk for desmoids that are inherent to the type of surgery we choose.
I actually get this very much today, and I was like, oh, I'm gonna give them a call or something like that. But I just wondering, has anybody thought about or done any preventative strategies systemically? I haven't, but.
Yeah, no, thank you. I almost felt like I planted this question, but because we do have, a good way of assessing risk for desmoid formation after surgery. So, I think if we had a drug that is safe, again, when we use drugs for prevention rather than for treatment, they have to have an extremely, extreme safety profile. And tamoxifen, I think would be there. Sulindac, similarly. And in these FAP patients, we often use these medications, not the tamoxifen, but Sulindac will use it for polyps, right, for chemo prevention and polyps. So I really wanted to take my patients that are high at desmoid risk and start them on tamoxifen and Sulindac before surgery and see, if I could prevent desmoids. My sarcoma oncologist didn't think it would work, but I think it would be, if we can find a medication that we think would work, that is safe, we would need a large group to do this, and that's, DTRF, I think, is in a good position for doing that, to enroll patients in a prophylactic trial where we take them before surgery. The additional wrinkle is that a lot of these patients are children, which makes it even tougher, but I think it would be a great idea.